All right. Today we're going to talk about acute coronary syndromes, everyone's favorite topic. And by that, I mean it's my favorite topic because I'm a cardiac nurse. Um, every example I give seems to be in relation to something cardiac. So a little bit near and dear to my heart here. Get it? Hearts. Um, anyway, that's enough jokes for me. So if anyone's forgotten, this is me. I'm just going to skip over this one, but you all know me. I'm the regional critical care educator. Um, reach out if you have any questions or you want to know more about sort of what I do. But we're going to talk about a few things. It's kind of like a high level overview of acute coronary syndromes and three distinct subtypes. There's a few more, but I'm sort of going to just mention the other ones, but focus on unstable angina, NSTEMI, and STEMI. But at any time, you guys have any questions, just like you can just shout it out or put your hand up, whatever you prefer. So just as a quick recap, everyone knows most of this information, but we're going to talk a lot about ECG findings, both 12 and 15 lead ECG findings that are common with mainly STEMI and NSTEMI. And those key ECG changes that we're going to see infrequently QRS morphology or the width of the QRS complex, but most commonly the T wave, its morphology and whether or not it's inverted or flattened, and then ST changes, both depression and elevation. Those are the big ones. So what is acute coronary syndrome? It's sort of like a big blanket term. It includes a lot of different pathophysiologies, both stable and unstable angina. Again, we're going to focus on the unstable angina uh, because by nature, stable is controlled and predictable and medically managed. But it has the same pathophysiological mechanism. So if you can understand unstable, stable is very similar. And then NSTEMI, STEMI, and then there's also variant angina, or also Pritz-Metals angina. It's a vasospastic angina, so it has nothing to do with the same pathophysiology that the other types have. It's caused by vasospasm, either caused by some sort of stress. It could be predictable or unpredictable. It's usually medically managed with calcium channel blockers, beta blockers, things like that. But it has some of the same symptoms on its onset, and it can look a little tricky when trying to diagnose. So this is a little bit of an overview. Um, Unstable angina, STEMI, and NSTEMI. The two STEMIs, NSTEMI and STEMI, we're usually referring to a calcification or like a blockage and a complication thereof. Whether or not it's causing those classic or typical ECG findings is when we're going to classify it as STEMI or NSTEMI. And then unstable angina can be caused by a few things. It could be also caused by rupture, plaque rupture. It can be caused by some of the same physiological mechanisms as NSTEMI, but it causes damage, but not permanent damage to the heart. So sometimes it could be a precursor to NSTEMI or STEMI, but they all have the same risk factors that we're all intimately familiar with: smoking, diabetes, hypertension, genetics, family history. Um, Other than smoking, uncontrolled hypertension is the key. It's the number one modifiable risk factor for acute coronary syndrome. So if you have your typical patient who you may be looking after or seeing in emerge or the ICU, wherever you may be seeing them, and they have a whole laundry list of medical history items, and they smoke a significant amount of cigarettes, And for example, I'll use one of my patients as an example. They also do stimulant drugs and cocaine, and they ask you for suggestions on how to quit smoking because they really want to get their health under control. We might have to do a little bit more family or patient education as to, like, ways to think a little bit more creatively about um, their risk factors, you know, trying to be realistic with patients and their habits. People often, like when you're seeing them after a catastrophic heart attack, they, have this strong desire to change, but usually it's not um, realistic and permanent. So it could be a great motivator to change, but we have to be realistic sometimes. So managing expectations is important. Um, there are some key differences when we're talking about the symptomology of acute coronary syndrome in male and female patients. Um, a lot of the symptoms can be the same, so don't perceive this diagram as being like the symptoms being mutually exclusive to one group or the other. However, male patients typically present with uh, the more stereotypical signs of a heart attack, lightheadedness, crushing chest pain or pressure, that can radiate to the stomach or to, like, the left shoulder, the arm. Whereas the symptoms associated with ACS in female patients can be a little more subtle. Um, Anxiety, dizziness, it might present as some shortness of breath or just nausea and vomiting. So it can really mimic other conditions like the flu. You're feeling run down, tired, you're a little nauseous, and you've thrown up. It could be a whole slew of things, and sometimes the last thing we're thinking about is an MI. So this is why statistically it goes under diagnosed in women, and they have a higher mortality rate than men. This is changing because there's a recognition of the differences in presentation here. I had multiple patients with really vague symptoms. I had one patient very healthy, so of course was not thinking acute coronary syndrome, was actually playing tennis and just then developed some persistent elbow pain, which she had had in the past. So, like typical, you know, last thing on her mind was a heart attack. Goes home, ices her elbow, and it's just like sort of the same pain as she normally experiences after, a pretty good game of tennis, except it just didn't go away. So she had actually the forethought to go into emerge, and for whatever reason they did an ECG, and she was having an anterior STEMI. So you never know. Um, can't talk about acute coronary syndrome and all the different ECG patterns without talking about ECGs. So if you were wondering, there are a million indications for an ECG. Chest pain, tightness, shortness of breath, or any of those symptoms we just talked about are indications for an ECG. Really any patient you may see. I just want to go over a couple types. You are all probably very familiar with, the types of ECG, but there's a couple minute differences when it comes to 15 lead ECG. So just wanted to mention quickly. We're going to talk about right-sided STEMIs, or trying to rule those out. So we may get orders for those, and there's ways to get around some technical difficulties if we have like one brand of ECG machine, or you're using a bedside monitor and you're trying to perform a 12 lead ECG, and you can't find the additional leads to perform the 15 from a 12. There's ways to sort of take some of those leads and create a 15 lead. So this is your typical 12 lead. There's 10 physical leads. It's going to display 12 different waveforms. And those waveforms, we're going to go over what anatomical areas and what arteries they correspond to. Usually the precordial leads V through V1 through V6 correspond to the anatomical area that they're resting over, so the septal, anterior, and lateral walls of the heart. And a 15 lead ECG, just a quick overview of the typical placement. And I say typical with a little bit of an asterisk here, because we use Philips ECG machines. Some places use GE. They both will have fairly similar diagrams actually on the machines on how to place the leads for a 15 lead, and usually don't include V4R, but they may. Um, Usually they do include a V7, 8, and 9. At least that's how Philips says. And they'll show you exactly where to put them on your patient. So you're not actually moving any of the leads you've applied for a 12 lead. You're just adding 3 additional ones. I wanted to show these 2 pictures because often from my days in Emerge, we don't use the same bedside monitoring equipment that is equipped with a diagnostic 12 lead. And sometimes we have to think on our feet and be a little bit more flexible. So there's ways to actually start with a 12 lead and move leads V4, V5, and V6 to obtain a 15 lead. So you move V4 to the right side of the chest, relabel it as V4R, and you're moving V5 to the posterior chest, to the back, mid-scapular line, and that same intercostal space, we're calling it V8, and V6, we're moving just between that lead V8 and the spine and calling it V9. So once you do that, you just physically move those leads on the patient's chest and print out another 12 lead as if you were doing it normally on your machine. And once it actually prints out in old-fashioned paper, we can then actually just relabel the leads in pen. Doing that isn't ideal. I know we all use electronic charting these days. And again, defer to your organization's practices because often the machines can do a 15 lead and then they can be uploaded as a proper 15 lead into the electronic health record. But time is of the essence. And if we can't find that piece of equipment or it's not working for us, we can quickly rearrange some of the 12 lead ECG leads, like um, just these ones that we've already placed. We're seeing some subtle lateral lead changes, and we want to confirm or rule out a right-sided MI. We can then just do another one with some minor changes and print it out. So that's my little tip there for a 15 lead. Usually, I know, at least in my experience, every time, it's not often we get asked to actually do a 15 lead, or if somebody a lot smarter than me says, hey, why don't you do a 15 lead ECG? I kind of panic a little bit because I always forget how to do it. So there's a couple ways to do it. There's also a right-sided ECG where you're literally just transposing the typical 12 lead ECG locations to the right side. It's not nearly as typical as what I just showed you. So just as another overview there, unstable angina and STEMI and STEMI. Um, Unstable angina, it's angina as like the broad term for referring to cardiac induced or cardiac cause of pain. It has an unpredictable pattern, so it can occur at rest. Usually with stable angina, it's caused by the same physiological mechanism. It may be as a result of a plaque that's there or vasospasm, a lot of different mechanisms, but it's predictable in nature. Somebody knows that they have cardiac related pain and they know it's going to happen if they climb 5 flights of stairs or they run around the block or even climb up from the basement to the top floor of their house. They know that they're going to have to pace themselves because they'll develop chest pain. Or they carry a nitro spray, and usually after one spray and some rest, it goes away. Unstable angina is that to the extreme. It is a change from the normal baseline. It occurs at rest. It's unpredictable in nature, and it may indicate uh, some sort of evolution of the disease process. Can be a precursor to one of these types of MIs. And so the difference in when we're talking about an MI, a myocardial infarction, is the NSTEMI and STEMI is that with an NSTEMI, we're not seeing ST elevation. But so it can be as a result of a partial or an incomplete blockage of that coronary artery, but still enough is blocked that it's causing those symptoms and then myocardial damage. Plaque rupture would be a good example where that plaque is sort of incomplete because of turbulent flow in the artery. It's intermittently completely blocking the artery. We see those dynamic changes in a 12 lead. Sometimes we see ST changes and sometimes they dissipate. And a STEMI would be that stereotypical ST elevation. And that is indicative of a complete blockage of a coronary artery. Damage is occurring now, and we need to do something about it, typically within 90 minutes. Like I said, the symptomology differs between genders and individual factors. So they may be similar in a way, really, if we're comparing all three types here. There may be some ECG changes with angina and STEMI. You might have ST depression, T wave inversion, might have cardiac enzyme that are detectable or extremely elevated. So they're not, especially in a case of a severe NSTEMI, it's not really matching with some of the ECG patterns that we're seeing. So that's when we start to get a little bit more worried about our patients. STEMI, we're going to see a predictable pattern: hyperacute T waves at first, with new ST elevation, with in the limb leads and precordial leads, depending on the anatomical location and what arteries are blocked. Later in the evolution, you might see some pathological Q waves that indicates that cell death has occurred. ST elevation, no oxygen is getting to the cells. And depending on the onset of symptoms and how early the patient may be presenting to you, you may not actually see cardiac enzyme elevation, unless, of course, we're monitoring myoglobin, which nobody takes anymore. So troponin takes a couple hours. So if they've presented within like an hour to the hospital, or EMS has picked them up and brought you to them, or brought them to you rather, you might see a normal troponin, but they're clutching their chest and they're extremely symptomatic, pale, diaphoretic, and they're having those ominous changes in their ECG. You know what's going on there. So focusing on the ECG here, when we're trying to establish ST elevation and ST depression, I have the next slide here talks about, or the next couple talks about what the J point is. It's the point of the waveform right after the S in the QRS. So measuring from there, comparing it to the baseline, ST elevation is when the ST segment is greater than or equal to 1 millimeter above the baseline, or the isoelectric line. So in the septal leads, V2, anterior leads V2 and V3, the ST segment 1.5 millimeters above isoelectric line is considered normal for women, but 2 millimeters for men. So the threshold's a little bit lower. Like I said, erring on the side of caution, literature has suggested underdiagnosed, so we have a little bit lower threshold. And in order to diagnose STEMI or STEMI activation criteria, all of you may be familiar with this, ST elevation needs to be present in 2 or more contiguous. These are anatomically contiguous leads. If you don't know what that means, we will go over what that means. ST depression, again, monitoring from that J point. You can also look at the entire ST segment as a whole. We monitor from that J point, just to sort of recap, because sometimes there is not a significant section of actual baseline between the QRS complex and the T wave. For whatever reason, patients may have electrolyte abnormalities that cause like a hyperacute or really peaked T wave. So any deviation greater than 0.5 millimeter below the isoelectric line is considered ST depression. And in those anterior leads, if there's any ST depression, even if it's less than 0.5 millimeter, it's considered abnormal. A pathological Q wave means the QRS complex usually does not have a pronounced downward deflection in that Q wave. It's not typically seen in especially those anterior leads. And if it's seen in those leads at all, it's considered abnormal. If it's seen in any of the other leads and it's more than 2 millimeters, or it's wider than one small box, so 0.04 seconds, it's considered abnormal. It may indicate damage has occurred at some point. So it could be pointing us in the direction of like an old MI, or it might give us some hints as to what is actually going on with the patient in front of us now. If they're having cardiac related symptoms, no ST changes, but over the next number of hours, they start developing Q waves. it kind of gives us a little bit of a hint as to what may have been happening. T waves are typically upright, except in AVR and V1. So T wave inversion literally refers to flipping of the T wave, and it could indicate ischemic changes as well. So just being mindful of all of those things. An example of an N STEMI causing some T wave inversion. Just remember AVR and V1 T wave is typically inverted. I mentioned the J point. That little line is pointing to the J point. Sometimes that T wave is awfully close to the QRS complex, so you don't have an obvious section of ST segment there to actually be looking at and comparing it to the isoelectric line or the baseline. So if you just take that point where the QRS complex meets the T wave and we're measuring from there, that's the standard. And just a little recap there of ST depression, ST elevation. Again, we're looking for 2 or more contiguous leads, and anatomically contiguous means they go together in the same anatomical area. The next slide goes over that, but just to recap Q waves, there may be some in some leads very small Q waves, but if you keep some of these parameters in mind, you know, that depth of that Q wave is over 25% the depth of the total QRS. It just looks abnormal. It doesn't look like the patient's previous ECGs. Like I wouldn't write down all of those like characteristics. You might have a conversation with many members of the team. You're really worried about this patient, and we're comparing our ECG now to previously, and now we're seeing these really big Q waves. It can give us a little bit of a hint of an old infarct, or whether or not we're actually going to treat the injury that's occurring now. So that's kind of a big distinction to make. ST elevation means there is an active blockage happening while we're observing the ECG, but the Q waves indicate cell death has occurred. So if we are no longer seeing ST elevation and significant Q waves, sometimes physicians will say the patient's Q'd out, or the infarct is complete, it's transmural, or it's occurred in the entire thickness of the myocardium, and the risks of actually putting the patient through a cardiac angiogram are greater than the benefit. So the risks outweigh the benefit. Rarely is that conversation actually happening when we have a STEMI activation, unless the patient's really advanced age and they have, you know, wishes not to be resuscitated, things like that. These are the anatomically contiguous leads that I was talking about. So they go together. These are the groups of leads. You've probably seen different images online. You might have a tag on your badge that sort of indicates these from Core Health. 2, 3, and AVF are our inferior leads. V4R, V8, and V9 are added there, just for some context. V or AVR is just for reference. It doesn't really point to any anatomical location at all. And when you look at the V leads or the precordial leads, that is the anterior and lateral portions. So V1 anterior, V1 to V4 you can consider anterior. Depending on the diagram we're looking at, sometimes they're referred to as the septal leads. So anterior septal MI you might hear. Septal leads are those V1 and V2. We can also just call them all anterior. When you start to get to the V5 and 6, those are under the patient's underarm there in their axilla. And lead 1 in AVL, that's indicating lateral wall involvement. And then obviously our V8 and V9 are on the patient's back, so they're posterior wall. So if we're having subtle changes in the lateral wall, sometimes that's why we'd want a posterior MI or 15 lead ECG rather, just to rule out circumflex involvement or that artery that typically wraps around the posterior wall of the heart. Another diagnostic characteristic of STEMI is, again, we're seeing ST changes that are not greater than, but around 2 millimeters in some anatomically contiguous leads. Something else to look for is you have reciprocal changes, or the opposite ST segment change. So if you have ST elevation, you'd have ST depression in the anatomically reciprocal area, so the opposite area. So in the case of inferior MI, so that's what's displayed here in this ECG. So you have 2-3 AVF elevation. The reciprocal area would be the lateral leads. So looking at lead 1 in AVL, you have ST depression in those. So that's another telltale sign that this is indeed diagnostically significant ST elevation. You're looking at the anterior or the septal leads. Reciprocal changes would be on the posterior wall. So just another way to look at it, you have ST elevation and pathological Q waves in 2-3 or AVF. Those are the inferior leads. You can have ST depression and T wave inversion in the lateral leads. The lateral leads, you have ST elevation. You can have ST depression in the inferior leads. You're not a visual person. The ST changes can look different depending on the anatomical area. These are some typical, and I use air quotes here, typical morphology. Wouldn't take them to the bank. Everyone's a little bit different, but of note here, I would keep in mind what artery we're talking about, what coronary artery typically that those contiguous lead areas are pointing to. So if we're talking about the inferior leads, and it's a little bit confusing because they're a different color scheme here. The inferior leads 2-3 AVF. We're talking about the right coronary artery, the lateral wall, and posterior. So 1 AVL, V5, and V6, and you can also add V8 and V9 in there. We're looking at the circumflex artery and the septal and anterior leads, V1 through V4. We're looking at the LAD, left anterior descending. So these are our time targets. If for those of you who do moonlight in the emergency department, you're pretty familiar with these. These also go for any patients who are already admitted to hospital and they develop new cardiac related signs. So early recognition is the key. So we want every patient who has cardiac signs and symptoms to have an ECG within 10 minutes, and interpretation of that ECG within 10 minutes. So that's not just taking the ECG and putting it in their chart and having them go wait in the waiting room. I'm sure no one's doing that with their patients who they really think are having a STEMI, but I do have to say that. And once a STEMI is recognized, if we're not PCI capable at the facility we're recognizing this in, we want them in and out within less than 30 minutes. Usually that comes with a regimented process of STEMI activation. There's a centralized phone number. We're all speaking the same language in this area, and we're all going to activate code STEMI with the interventional cardiology team at RVH. But if you do work in another area, likely the time targets will be the same. We're just referring to a different PCI capable site. There is some areas in our region that this 120-minute target becomes a little iffy. So if we are within a 2-hour drive to a PCI capable center, our main treatment modality will be PCI, so percutaneous intervention, either thrombectomy or stent or both. So there's some areas, around Parry Sound, it's about the same distance from here as it is to Sudbury. So depending on where patients are, if they're on the road or they live between here and there, they may be referred to Health Sciences North or here. Same goes to our friends up in Huntsville or anywhere in between. Start getting south towards Highway 89. Everyone gets sent to South Lake. So just keeping an eye on the things and the little bit of a story. We're going to go over some examples of STEMI stories. So we publish because we're the regional STEMI site, and you may have seen some of these stories or be familiar with them specific to the patients that come from your facility. But I have STEMI stories from regional EMS partners and all the other hospitals in the area. So just an example of a little blurb or a small snippet of their history. When did the symptoms begin? The qualifying ECG that we activated STEMI from, if they had a cardiac arrest, what time we achieved ROSC, what their hemodynamic status is, so if they're stable, just a set of vitals and just communicating that they're stable. If they have a medical history that's cardiac in nature, um, medications and the copies of the ECGs. Other than that, patients can leave as fast as they can. We can also make sure we fax or send all those pieces of information if we really have to leave with the patient quickly. Just to mention, we're not going to spend a lot of time on the other medical management, but remembering the initial stabilization of our patients. We used to use that MONA acronym: morphine, oxygen, nitrates, aspirin. A lot of those things are still applicable, especially ASA, aspirin, um, some other antiplatelets, Plavix or ticagrelor is a common one now. Those are some first line medications that we almost always give unless there's a documented allergy. And depending on the cardiologist recommendation, we may or may not get orders to administer a heparin bolus. We usually will do that when the patient presents to RVH, but depending on how far the patient is or where you're sending them from, and communication from the cardiologist here, you may give those at your site. I just wanted to mention, for those of you that don't know, if we're seeing signs of an inferior wall MI, so those 2-3 AVF, patients are really symptomatic or sensitive to any medication that can reduce preload. Nitroglycerin is like the main culprit here. So I would use with caution. Maybe I would go as far as to say stay away from nitro altogether unless our physician colleagues are extremely confident in us administering those to the patient. Often that's our first line medication. There's medical directives that spell those out depending on your hospital, but they will say use with caution and inferior MIs. We can sometimes cause preload reduction, and when our patients are having inferior wall MIs, it's affecting the right ventricle, and we're really dependent on whatever preload or filling pressure there is in the heart to maintain our hemodynamic status. So if we reduce that by dilating all those, the venous system, we could lose a lot of that blood pressure, and it's really hard to get back. Morphine can also reduce preload. Lasix, not so much an urgent concern. Just adding initial stabilization points there if our patients are symptomatic or all just hemodynamically unstable on presentation. Vasopressors, inotropes like epinephrine, norepi, dopamine, these are common ones. Point about oxygen, we used to just indiscriminately administer oxygen to everybody, just keeping in mind, unless there's extenuating circumstances, patients don't necessarily need oxygen unless their SATs are less than 92%. 88 if their patients have COPD. And they also may require intra-aortic balloon pump. So that's a mechanical counterpulsation therapy that we do at RVH post PCI. So I'm going to quiz everybody. I'm just kidding. I'm not going to quiz anyone. So just to sort of recap a couple of ECGs just for those ST depression elevation conversations we were just having. Blue means depression and yellow means elevation in these slides we're going to look at. There is some pathological Q waves there in lead 3. So if you look at the baseline there in leads 1 to AVF 5 and 6, comparing that ST segment, every single one of them, there is some slight depression, not any more than about half a millimeter, but the presence of those Q waves in lead 3 sort of lead us to believe there's something suspicious going on here. So widespread ST depression in those leads, we call this dynamic ST depression. If you've ever seen or had patients with these patterns, and we have the capability of doing continuous 12-lead ECG monitoring, they could be experiencing those changes when they are also having chest pain. So if it's unstable angina and they've been diagnosed with NSTEMI, when they're having a significant increase in their chest pain, you can actually see these dynamic or rapid changing ECGs. It could be a precursor to, developing a STEMI.
Yeah, no.
Here's another 12-lead ECG. Lead 1 and AVL have some slight ST elevation, about 2 millimeters there, and T-wave inversion. So those are the lateral leads, and remembering the reciprocal leads for our lateral leads are the inferior leads. So we are seeing some very slight ST depression in those leads. So 2 leads that are anatomically contiguous or they're anatomically together, we're seeing slight elevation, some Q waves, and then also reciprocal changes in those leads that would meet STEMI criteria. It's very subtle. So that's why I like to show that one. So this does take some time. This one's a little bit more dramatic. I just wanted to see if I miss anything here. This one's a little bit more of a dramatic example. The patient also has what looks like could be a bundle branch block, but in those inferior leads, we have a lot more dramatic ST elevation occurring. Definitely some very pronounced Q waves in lead 3 and AVF. And AVL, we have some reciprocal depression there. That's our inferior STEMI there. Remembering, use nitrates with caution there. Also monitoring for bradycardia. If we recall, the right coronary artery is responsible for perfusion of the AV node. So very common for patients to present with hemodynamic changes and associated bradycardia. So if they present to you with an inexplicable complete heart block, but they're also having chest pain, I would be really suspicious for the patient A to be meeting STEMI criteria, and then B, that be the reason for their complete heart block. So we need to take care of a couple things, i.e. the blockage first, support their hemodynamics with temporary pacing, and then they may also need a permanent pacemaker afterwards. A lot of things going on in this one. So Q waves occurring in V1 and 2, but the highlight there is the ST elevation leads V2, 3, V4, 1, and AVL. So that is anterior lateral ST elevation. We do have some depression in lead 3. Those extremely tall T waves, you'd call those hyperacute T waves. So this is a fairly early STEMI, even though we are seeing some Q waves. I just wanted to mention also talking about bradycardic changes with inferior MIs, because we're worried about that right coronary and its perfusion to the AV node. The higher degree AV blocks, second degree type 2 complete heart block, when they're associated with anterior ST elevation or anterior STEMI, the mortality rate goes down significantly, because if we're causing those sort of electrophysiological changes and affecting the anterior wall, enough of that myocardium has died or is dying, that's affecting the conduction system much farther up. So I would urgency, increases even much more there. So I'm not sure how well that's coming across on your end. I got a little carried away when I was reviewing my emails for STEMI stories here, so I tried to cram a couple in each slide here. Tried to add one for each one of our friends here, but just bear with me. This first one on the left is a Simcoe County paramedic STEMI story. patient, not sure where they came from, but called with 7 out of 10 chest pain radiating to their arms. They felt weak and nauseous. They took ASA and called 911 and described the pain as heavy. Also reported having some diarrhea. So again, ominous sign there. The initial 12 lead had some artifact because the patient was moving. Did another 12 lead, showed that complete heart block with ST elevations in lead 2, 3, AVF, V5, and 6. So 2, 3, and AVF, those are the inferior leads there, and a complete heart block. So already ST elevation, bradycardia, alarm bells are ringing. We're already thinking right coronary artery. So this patient, I think, was hemodynamically unstable, bradycardic, required fluid bolus, dopamine infusion, and transcutaneous pacing in the field. Sorry, no, transcutaneous pacing not recommended due to no analgesic on board. So they obviously shied away from doing that. However, you know, worst case scenario, they could have resorted to that as a last case or a last ditch effort. But there is the pictures of the angiogram before and after. We have a 100% proximal blockage of that RCA, and then a nice deep breath, nice blood flow after there. There is some stats there that sort of show door to ECG, door to arrival at RVH, and then door to balloon or door to device time. That is the time they entered RVH and to the time that we deploy a stent and regain patency of the artery. So those are the target times. Often we do meet them, which is good across the board, but sometimes there's challenges and we sort of try and figure out where those are and smooth those out. So this next one is a Collingwood patient. Woke up with pain in their chest, back, down both of the arms. Patient ambulated. Pain got worse, called 911, and was brought to the Emerge in Collingwood. They described the pain as being heavy, like electricity down both arms, and the patient was diaphoretic. 12 lead ECG showed AFib and some ST elevation in leads 3 and AVF. Subsequent 15 lead showed ST elevation in lead V4R, which indicates the right-sided ECG. So wasn't diagnostically accurate enough with just the 12 lead. So they sort of took those lateral findings in the 12 lead, added that 15 lead. That's why I wanted to show this one. And you see some subtle elevation V4R and then depression in those posterior leads. Code STEMI was activated, and you see there we got a distal RCA lesion, 100%, and a 90% calcified ostial RCA, which ostial means right at the beginning of, or the ostium, the opening of that artery. It being a calcified lesion, usually they're going to monitor things like that, and deploying a stent right at that opening of that artery, if it's calcified, can actually cause more problems than it would solve. It can cause an arterial dissection and block the entire artery as opposed to just the distal end like we had before. But you can see their blood flow to the inferior wall is much better. Some more dramatic examples here. Patient had an ECG within 3 minutes on the one on the left here. The patient woke up from a sleep with 9 out of 10 chest pain, burning sensation that didn't go away, radiated to their back. And when they were standing, they felt weak. When the EMS got there, they looked extremely unwell, ashen in color. 12 leads showed some inferior ST elevation, 2-3 AVF. And there's a nice 100% blockage at the ostium of the RCA. You can see the nice results there after deploying that stent. This patient here, this was another EMS patient, 10 out of 10 pain, radiating to the retrosternal area, bilateral arm numbness while they are at work. They experienced vomiting and nausea. The patient's spouse picked them up, drove them to the hospital, but then called 911 en route because the patient became hypotensive during and needed some help. They were hypotensive during transfer. They started a dopamine infusion. The 12 lead shows some dramatic ST elevation here. V2, V3, lead 1 AVL, and reciprocal depression in the inferior leads. They needed to be intubated, inotropic support, and an IABP inserted in the cath lab and maintained post. An IABP intra-aortic balloon pump, counterpulsation. It inflates during diastole and rapidly deflates during systole to do a couple things. They want to promote blood flow to the coronaries. They fill during diastole. So if you have a really significant blockage like this 100% ostial LAD, we want to maintain the patency of that artery after we intervene. And then also that rapid deflation during systole helps create a negative pressure and to actually help pull some of the blood out of the ventricles. Doesn't really help that much with peripheral circulation, but it helps a lot to maintain coronary patency. Last slide. So this patient was an RVH ED activation. They woke up during the night with worsening chest pain, called 911, STEMI positive with EMS, but the patient went into VF requiring one defibrillation to ROSC. I think it was early enough, didn't say they had chest compressions. Intermittent runs of VT also noted in emerge. So that's why they would have diverted to emerge because of that instability. They did a 15 lead at the hospital. So leads 2, 3, AVF, V4, V5, and V4R, all showing ST elevation. And you can see there the 100% proximal RCA. So, it doesn't really matter what coronary we're talking about. This ventricular ectopy is a concern no matter what. More common with the left ventricle, the LAD lesions. But a significant enough blockage, you can cause those VT and VF. And this last one here, patient woke up with left-sided left arm pain, didn't think much of it and went about their morning routine. Pain continued throughout the morning and developed some mild chest discomfort and started dry heaving. At 12 o'clock, the patient had a witnessed cardiac arrest. This was a RAMA EMS, by the way. CPR was started immediately and they defibrillated the patient 3 times. They got ROSC, called 911, and the ECG showed anterior ST elevation, indicating an anterior STEMI. And you can see there 100% proximal LAD with a lovely picture after revascularization. So unfortunately, doesn't really give you a complete picture. I don't have the story after the patient was treated in the cath lab, but at least their coronary arteries looked marvelous after they were treated. But this kind of gives you a little bit of a history here. Does anyone have any questions about acute coronary syndrome, ECG interpretation, anything I didn't mention? All right. Thanks for logging in. Just gonna stop the recording here.